Our next speaker is Dr. Adam Myers, the Senior Vice President and Chief Clinical Transformation Officer for the Blue Cross Blue Shield Association, a national federation of 34 independent, community-based, and locally operated Blue Cross Blue Shield companies. Dr. Myers is board certified in family medicine and served on the faculty of the University of Oklahoma Obstetrics and Gynecology Department. He is key to the work that Blue Cross Blue Shield plans around the country are leading to address maternal mortality. We are grateful to have Dr. Myers with us today to share insight and solutions from the Blue Cross Blue Shield strategy. Dr. Myers?
Thank you so much, Cherie, and thank you for my colleagues who preceded. It's tremendous research that you've all shared and great strategies about how to tackle this as well. One more bit of color, I was privileged in a variety of different roles prior to this to have the opportunity to attend the birth of thousands of Black and brown birthing people, and it was just a humbling experience, and I bring some of that to this table as well. The Blue Cross Blue Shield Association, as Cherie said, is an organization that represents and convenes the independent blues plans across the United States. In aggregate, we bring to the table 115 million, or 1 in 3 Americans. This work has evolved over the last several years. Next slide, please. In 2020, there was a decision to determine what can we as a blue system do to address the inequities that were becoming very, very real during the pandemic. They existed long before that, but they were being amplified during the pandemic. And the health equity strategy focused on the things that you can see here: vaccines, ensuring that they were equitably available, data leadership, being able to get REL data on our members, on the patients, and on providers as well, to ensure that we could have networks that could support that connection. We have a national health equity program, which we're going to dive into a little bit as well, and then discussions about our networks, who's in our networks, and how do we incent, as Dr. Srinivas said, and pay for advances in health equity. We grouped together industry leaders into a national advisory panel. We've made significant policy and advocacy efforts as well. And as both of my colleagues have stated, this can only be done in partnership. These challenges are large enough that no one stakeholder can tackle these alone. And so working together is critical as we move forward. Next slide. Back in the end of 2020 and early 2021, based on data that existed at the time, as is the others prior to this, we realized that Black and brown women were 3 times as likely to encounter complications of their pregnancy that classified as SML. And we declared a public goal to reduce racial disparities in maternal health by 50% in 5 years. Now, this wasn't just for the Blues members. While 1 in 3 Americans is pretty material, we want to be even larger than that in our impact through partnership with others, such as those on this call. So this was our bold goal, and this was based on data that we had available to us at the time. Next slide. We also convened a group of health equity champions from across the Blues that focused our efforts in this about conducting cultural competency training and inclusive bias education, and partnered with the March of Dimes to that end, supporting the practice of nurse midwives and doulas, expanding access to maternal support services such as doulas. We wanted to expand the care continuum to include greater coverage into the postpartum era for up to a year, and then also assess provider program opportunities for reducing disparities, such as centers of excellence and incentive programs. Next slide. In looking at the literature and in looking at our data, we determined that these would be 10 maternal health equity actions that we could take across our Blues system. Each one of our Blues plans right now is vigorously working to implement as many of these that they can at pace, given their local resources and the partnerships that they have with providers in their areas. But they focus on the strategic pillars that I've defined before. Next slide, please. We also just revisited the data, and early on, others have spoken about the fact that the data and data points that have been described so far have been based on available data up until 2020. Well, we have dug in deeper and have now found data that includes part of 2021 from across our 115 million members. We also added a national Medicaid data set into our analysis. We also surveyed our members and analyzed their experiences based on patient-reported data. Additionally, we did analysis of SMM using our definition. The traditional definition of SMM by the CDC oftentimes gets reported based on discharge data alone. And given the fact that a significant percentage of adverse outcomes occur in the postpartum period, we felt like it was important to include those in our analysis. So we have advocated to NQF and others to extend that SMM standard to being inclusive of events up to 6 weeks postpartum. And for the purposes of a research study that we are about to release this week, that's the analysis that we're bringing to bear from across our 115 million members and a national data set for Medicaid. Next slide, please. What did we find? We found that SMM rates over the time period from where my colleagues had discussed and where we had previously published data have worsened by 9% in both the commercial and in the Medicaid space. That SMM rates are higher among Black, Hispanic, and Asian women, as what we have seen, and that this holds true for both the Medicaid and commercially insured populations. Having commercial coverage, having the financial means and the standing to have commercial coverage is not a buffer against these adverse outcomes. That's really important and underscores many of the things that my colleagues have stated prior to this. There are a number of factors that increase the risk of SMM many times over, and those are oftentimes comorbidities, clinical comorbidities that we have found through analysis that exist pre-pregnancy, that are carried into pregnancy, that make the likelihood of adverse outcomes much, much higher. And in our survey findings, we also find that Black and Hispanic women find that they are less likely to be able to make their prenatal visits, and we have two distinctive reasons for that. One would be ease of scheduling, and the other is transportation. Let's dig in a bit. Next slide. SMM rates amongst the Blue Cross Blue Shield managed Medicaid lives are lower than the national Medicaid rates. And the presence, as I've stated, of chronic disease burden preceding pregnancy strongly correlates with higher SMM. One specific risk profile really rose to the top, and we'll see that called out in the data in just a moment. And that's for women of color ages 35 or higher with comorbid conditions. We believe, based on these data, that they should be treated as very high risk for SMM, delivered with perinatal support to those ends and the type of high surveillance that is necessary to accompany that. Compared to white mothers, a significant percentage of mothers of color, again, as we stated, were not able to complete the recommended number of prenatal visits, secondary predominantly and self-reported data to transportation and scheduling challenges. Next slide. So this shows the arc of worsening of 9%, and it has occurred for both the Medicaid population as well as the commercial data in our analysis. Again, 9% for both cohorts. Next slide. And I want you to look at this one. This shows the commercially insured SMM rate per 10,000 births. Just look on the right-hand side of the screen and look at that pattern. This is the commercial one, and notice where the absolute numbers are. Go ahead and advance to the next slide. What you see there is that the pattern is absolutely the same, whether they be in commercial insurance or Medicaid insurance. Again, commercial coverage is not the buffer that many think it is, and that these outcome trends exist regardless of payer. Certainly the absolute numbers are a bit higher in the Medicaid population, but that is, the patterns are the same. Next slide. And here's what I was referring to earlier. For the commercially insured, look at the spike there for Black women ages 35 who have any sort of comorbidity associated with them. It's a huge spike, tremendous spike in SMM there. And now let's go to the Medicaid data and look at the same. Next slide. Same spike there is observed for that population at that age. Next slide. And this has to do with the survey data, again, showing that for the Black members surveyed that transportation and scheduling concerns rose to the top as barriers for following through with the recommended series of prenatal visits. Next slide. So in addition to the top 10 list that I described earlier, there are certain actions that we propose would be strongly encouraged right now. We strongly encourage, and some of this is things that have been known for some time, but it's elucidated by the data that we've presented. Management of chronic diseases prior to pregnancy and subsequent to pregnancy is absolutely critical to ensure that women are healthier and safer to become pregnant before they move forward. Part of that involves extending postpartum care in up to a year postpartum, and we're grateful to see a significant movement in the Medicaid space for sure, and we're moving across our PPO coverage as well to include broader coverage for that. It's one of our top 10. And if you go to our Blue Cross Blue Shield website, there is a tracker that is published there that shows how this is working in the Medicaid space. More to come on that. We found that women of color are more likely to undergo potentially avoidable cesarean sections, and that based on our data and the previously published data as well, that it leads to an increased likelihood of complications as well. We also want to reinforce that the criteria for plans and providers for what scenarios are high risk for SMM, such as that very high risk population of women of color who are 35 and older with any comorbidities, really highlights that, the data really highlights that as a high risk population. And then underscore that there's significant need for attention, transportation, and scheduling barriers, but we know it's complex. As Dr. Srinivas said, sometimes even straightforward innovations are not as impactful as we'd hope. So next slide. We come to the area of question and answer. I am grateful to say that we will be releasing our Health of America report that delineates this in much greater detail, the update to our data set, and some more about actions that can be taken. And as I like to say, none of us can do this alone, but we alone can do our part, and all of this can only be achieved through partnership. So I'm grateful to be a part of this today.
Thank you so much, Dr. Myers, for highlighting the Blue Cross Blue Shield Association's high impact work in the national movement to reduce maternal mortality.